simplest questions that you can answer. The first thing that we're going to understand about an EKG is the EKG axis. What we call a EKG axis is basically the cardiac rhythm. That is, where is the heart current originating, and from the point of origination, where is it flowing into. This particular aspect is called an EKG. It will be called an EKG axis. When you're trying to understand the EKG, it is called as a 12-lead EKG. A 12-lead EKG is different from electrodes. If you have ever seen a person being placed on electrodes in real life or in the movies, you will notice that they place it on both the arms, both the legs, and across the chest. What is placed on the chest and on the arms is called the electrodes. It is different from the leads. The results from the electrodes is called the leads. I hope this point is clear. What is placed on the chest is called the electrode, and the resultant that we form from the electrodes is called the lead. So basically, EKG is the machine is a sensitive galvanometer which detects changes in the electromagnetic potential. So for the newcomers, for people who are just starting off, you hopefully remember the action potential. The sodium goes out and the potassium comes in. The currents that is formed because of that, which we call as the depolarization. So the depolarization followed by this and the repolarization phenomena. This depolarization and the repolarization, this would be detected on your EKG strip. I hope this is clear. As the cells would get activated, it would result in depolarization and in repolarization. This, when detected on a graph, will lead to EKG. So I hope you understood about the electrode versus the lead. There are two different types of leads as far as we need to understand. One we would call as a bipolar lead, and the other would be a unipolar lead. What you understand by a bipolar lead is that it would have a positive and a negative. So when it has a positive and it has a negative, the electricity would flow from the negative to the positive end. This would form a typical bipolar lead. These leads are your major leads, which are your lead 1, 2 and 3, which are placed on your hands and legs. How it is created, we would go forward to it. When you're talking about, I just read a point that you wanted to see the previous slide. This is the slide. There's nothing to be memorized from this. It is just a concept that we are trying to base. What we are trying to say is, on the EKG strip, we are trying to capture the electrical activation on the cardiac membrane. The depolarization of the heart cells and the repolarization would be caught on the EKG strip. What we mean by a lead and an electrode is the placements that would happen on the chest or on the arms. The lead would be the resultant from it. There are two types of leads, which is a bipolar lead and a unipolar lead. The bipolar lead means it would have a positive end and a negative end. And the electricity, as you know, has a negative charge, so it would go away from the same charge and towards the positive electrode. This type of bipolar lead are lead 1, lead 2 and lead 3. There are certain leads which is placed on your chest. Those, the precordial leads, which are called the chest leads, V1 to V6, only have one electrode, that is the positive charge, and everything else is taken as a 0. So it is from a 0 to a positive charge. There are something called as an augmented leads, which is the AVL, AVR and AVF, which are again single pole leads. Single pole leads, which is that is the reason it is augmented. So it just means that L is your left leg, L is your left arm, R is your right arm, and F is your foot. You don't need to copy all this. What you need to do is you need to understand what we are trying to do. What we are trying to do is, we'll get to it eventually, and I'll tell you where you need to make the notes. Okay? Any idea on who this guy is? So he is Sir William Einthoven, and he is the guy who created the string galvanometer, which is called the EKG. This is just a trivia so that I can help you all be very good, the person from Goa who answered. So he got the Nobel Prize for it, and people who are interested in trivia, he named it PQRS waves because he was not sure if they are the first waves of the heart or the last waves of the heart, which is back 200 years from now or 100 years from now. So that is why he named it PQRS, which is the middle alphabets, and he left the earlier alphabets and the later alphabets for anything if it is discovered later on. So we'll now talk more about how we generate the leads from the bipolar electrodes. When you said we have two electrodes, so it is basically, this is hidden for some reason. I'll just help you get a glimpse of it. So I hope it is clear now. So what we are trying to do is we are trying to place a triangle around the heart. What you're trying to do is you're trying to take a photograph from the up and from the bottom. So what you're trying to do is place different cameras at different angles so that you can image the heart from as many areas as possible. When you say image the heart, is you were trying to capture its electromagnetic potential. So the heart is kept in the center of the triangle, and all the axes of the bipolar electrodes are equilateral to it. So this is how it looks like. So when you say we have two electrodes, one at the left arm and the other at the right arm, what is generated because of this bipolar electrodes is called as the leads, which would be your lead 1. So the lead 1 with the arms outstretched would be looking at your heart from the top. When you keep one on the right arm and the other one on the left leg and you join them, this electrode would be your lead 2. Lead 2, if you look at it, it is looking at your heart from this is the right side. As you can see the vena cava here, so it is looking from your heart from the right inferior position. Similarly, the lead 3 is looking at your heart from the left position. So what you're trying to say is, if your heart is kept this way and here is your SA node and it goes down to your Purkinje fibers, it is starting from here, that is your SA node here, this is what your electricity is going to be, and this is how your current is going to flow. And the current always will flow towards the left side. That means it will, because the left ventricle will take more time to get activated, so the current will flow almost more towards the left side. So if you have only the 3 leads, for a basic understanding, your electricity flows somewhat like this. Is that clear? It starts somewhere very close to the lead 1 and it goes away from the lead 1 towards lead 2 and lead 3. We'll get more into depths of it, but this particular thing is called as the Einthoven's triangle. The Einthoven's triangle is an equilateral triangle. So all these axes are at 60 degrees to each other. Every angle here is 60 degrees. That's what is a equilateral triangle. So when you extend these angles backwards, you take these extensions backwards, you can form an axis here. And that is exactly what we have done. So this was your 2 arms that were outstretched, and this was your one side and this was your other side. We've just connected them to a point where they intersect. So if this is 0 degrees, 2 would be what degrees? It is at 60 degrees to that, so it would be 60 degrees. And lead 3 would be 60 degrees to lead 2, and hence that would be 120 degrees. So this system is the triaxial system of Einthoven. Now if you notice this, anything that starts at 0 goes to the other side, this angle becomes 180 degrees. Now conventionally, what you understand is, when I go from here, I can name it in 2 manners. I can either keep on increasing like 180, then it will become 190, so on and so forth till 360. But when I call it 360, lead 0 would become 0 degrees will become 360 again. So this was a big problem. This is a bit problematic, and what it is done is anything above this axis is in minus. It is the same degrees, but it is minus axis. So when lead 3 was 120 degrees, it is supposed to be at minus 60 degrees to lead 1. And similarly, it would be minus 120 degrees for lead 2. So what we'll do is, because to maintain a certain amount of smooth flow into this, I would appreciate if we can go, I'll try to explain it till the end, till I have come to the hexaaxial system, and then Manipal, I'll try to see if you have understood. If not, then I'll trace back a couple of steps. Is that okay? Okay. So the triaxial system is 0. What we did basically is, what we had this system and we just extended it backwards. We extended it backwards till the point we can find a axis. We could find a point where all of them bisect each other. Okay, this is how we came up with this triaxial system. So one more trivia, this is how the initial EKG looked like. So these are your lead 2 and lead 3 and lead 1, and this is how it is created. You can see Ithoven or whoever the first person was, he has kept his hand submerged into 2 electrodes which were nothing but salt water jars to detect electricity. So with this you understand how the axials, how they were trying to form the various axes here. Okay. Now, as we move on, so there are 3 more leads which are called there are other leads which are the unipolar leads. So unipolar leads, as we just said, that this has only one charge, which is a positive charge. So a positive charge, so every other is considered to be a 0 potential. The extremity leads have low potential, and to detect electricity from that low potential, they were augmented. So it is basically whatever recordings they're going to have, it would be increased by a particular level by the machine itself. Hence it is called as AVL. The A stands for augmented. This augmentation is represented by A. So we'll first understand how we are going to place the various precordial leads, and this can be very well understood by this. What I want you to do is pay particular attention to the heart. How is the heart structured and how we are trying to wrap around the heart in a particular manner. What we are trying to do, starting from the right side of the heart, we are trying to go all across till the left side. So what we do is we go from the 4th parasternal right up to the mid-axillary 6th intercostal space. Sorry, the 5th intercostal space. So we go to the 5th intercostal space, mid-axillary line. So this is this, which is in the 5th intercostal space. What we are trying to do again is, first we took pictures from the sides, and now we are trying to take a picture from the top. So when you're taking a picture from the top, this would not give you a fair bit of idea about the axis, that is the direction. It would be used in localizing of lesions. You can note this point, the precordial leads are most useful in localizing the lesions, because it would have different recordings for the right side of the heart and different recordings for the left side of the heart. When we were talking about the triaxial system, we came up with the 0, 1, the 1, 2 and 3 bipolar leads. Now this is a man standing right here who has one more leg here. So as this is the So this is that one lead is attached to the AVR, that is your right hand, the other is attached to your left, and the other is attached to the foot, which is your left foot. Because this is a unipolar lead, so it has no different, like it won't have a straight connecting line, but it would be a dot because it is plus only in that spot. There is no negative electrode here. To understand what we do is, we have placed this again. These are such that it is at 60 degrees to each other. So again the angle between this would be, all would be 60 degrees. AVF, which is your foot, would be at 90 degrees. So whatever would be your other lead would be plus 90, plus 60 degrees to that. If it is 60, the AVR here would be 30 degrees. And this is 60, this would be 150 degrees. Now, when we were discussing about the 1, 2 and 3 electrodes, we said anything that goes above, that is above 0 degrees on that axis, would be labeled in negative. So when this is plus 90 degrees, this would become minus 90 degrees. When this is minus 90, anything here would become minus 30 and anything here would become minus 50. Now, as the electrodes are actually placed in this area and not here, it is placed here. So the AVL is considered to be at minus 30 degrees and the AVR is at minus 150 degrees. I have two doubts. May I? So the thing here is, so this is what we are trying to generate, alright? What we said was, when we first had the patients, what we were trying to say was, we were developing a system, okay? When you saw this was the person who had the leads placed at different areas, okay? So this was your lead 1, lead 2 and lead 3. I hope this much point is clear. When you want to develop an axis, you have to extend these lines backwards. So these lines are extended where all these three are going to meet each other. Is this point clear? We have geometrically extended these lines so that they can meet. They would meet, again the angles would not change. We are doing this so that we can develop an axis. We cannot just assess it on the basis of a triangle, right? We have to develop an axis. Is that clear? If you don't develop an axis, you cannot identify only on the basis of a triangle, because the next leads that you have is here is AVR, here you have AVL and here you have AVF. So you need to delineate different axis groups, because this axis, where is this seeing, is this is seeing the heart from this direction and this is seeing the heart from this direction, okay? And this is seeing the heart from this direction. And all of it is at 60 degrees to each other. So this becomes 60 degrees. So as this is 90 degrees, this was supposed to be 60 when it comes this way and this way. Is it clear? I'm waiting for your answer. The point here is, you're trying to develop an axial system. So we have the AVL, the AVR. I'll redo the whole thing because this is important and this is not as difficult as it seems like right now. The thing is, when you have placed the electrodes, this was your lead 1, lead 2 and lead 3. Okay. When you made the augmented loads, those were unipolar electrodes and unipolar leads. So a unipolar would be AVR, AVR, AVL and AVF. Alright. This is like you have placed a camera at a particular point. If you have placed the camera here, this is a telephone camera and this is a telephone camera, you are viewing the heart from which axis? You are viewing the heart this way and you are viewing the heart this way. And this is something which is kept on the floor and watching upwards, which is this way. Okay. All of this axis would bisect each other. We can continue that and it will bisect each other. When it bisects each other, that angle would be 60 degrees. That is how it was made. You cannot say why 60 degrees because that is the whole purpose. It was created to be at 60 degrees. Now the point that you are facing, the problem that you are facing is you are confused how these electrodes are suddenly forming a axial system. What we did was, if you move this line, this left arm, and you draw it here, okay, I'll choose another color for you. If you draw your left arm, this would again be 0 degrees, right? This is also 0. This becomes your lead 1. Am I correct? This is how it is. The left lead, that your lead 3, was now we shift its angle in such a way that it intersects the 0 degrees. It will intersect here. Okay. This would become your lead 3. And your lead 2, again, you want a common origin point. You want a intersecting point. So you will shift your lead 2 and form it somewhere around here. So basically this line now is your lead 2, this is your lead 1 and it is your lead 3. That is your 3 angles, your 3 sides have now been shifted so that they intersect each other. Is this point clear? Is this point clear, Manipal and Goa? Okay, great. So when you have this angle, this is how you kept it. This was just to make you understand that when you created this, when you made this intersections, because they were always at 60 degrees to each other, when you shifted it this way, it is again at 60 degrees to each other. So the 60 degrees would always be static, constant between all the 3 different leads, that is lead 1, lead 2 and lead 3 will always have a 60 degree angle to each other. Okay. So if my lead 1 is 0 degrees, my lead 2 should be 60 degrees. And my lead 3 would be how much to lead 2? It would be 120, that is 60 plus 60. Okay. So this is basically this angle and this angle. Now to consider the angle between lead 3 and lead 1, you are seeing this extension back here. This would again be 60 degrees. Okay. But to call it lead 3, we need one place where it would be lead 3. That means this is your lead 3. This would be the opposite of lead 3. I don't think it is visible. It is the opposite of lead 3. This area, lead 2, this would be the opposite of lead 2. Okay. So when it is the opposite of lead 2, by convention, it is placed in minus. Those angles, anything above the 0 to 180 degrees would be in minus degrees. That means the same degrees would be repeated, but it would now become minus 90, minus 80, minus 70, minus 100, so on and so forth. When this was 0 degrees, anything behind 0, which is at 60 degrees, will become minus 60 degrees. Okay? Anything that is minus 60 degrees, and what would be lead 2 and lead 3? Difference would be 60. So this was 60, minus 60, minus 60. So this will become minus 120. When you are asked what is the axis of lead 1, that would be 0. What is the axis of lead 2? That would be 60. What is the axis of lead 3? Would be 120. Opposite of lead 3 would be minus 60, and opposite of lead 2 would be minus 120. I hope this point is clear. All right. After you have developed, so this is the basic triaxial system that was first developed by Einthoven. Okay, that is, you place the hands like this and one on the limbs, and that is how your 3 axis. If you see, the heart is now divided into so many 60-degree axes. All right, the electricity of the heart can be mapped on a 60-60-60 angle wise. You can divide it. That is what we are trying to do. But we also had 3 more leads which were placed on your limbs, which will also have a axis of their own. Okay, this axis system is the AVL system. Now when we drew on the first diagram, which I hope you remember, I'll just show it to you again. This one, you remember this. So we had the 0 degrees here, but we also developed the other axial system, which was of AVL, which we said would go right here and intersect it at a particular angle here. So this would become AVL. Your AVR will start here and will intersect at a particular angle, and this would be your AVR. And here at 90 degrees, again there is one more. So what you tried to do was, from the big 60-60 chunks, you again divide it into 30-30. That means between 2 different systems, the angle would again be 30 degrees. That is simply you're saying that there are 2 equilateral triangles which you are kept over one another. Okay. When you see this triaxial system of AVL, so the AVF electrode is at 90 degrees. That is your foot electrode. When you are standing erect, that is your leg. It is the foot electrode, which is 90 degrees. All right. I hope this is clear. So what you had was your lead 2, which was somewhere here, and if you remember, it was 60 degrees, lead 2. And you had your lead 3, which was here, and it was 60 degrees to lead 2. It was 120 degrees. Now you see the heart is placed into 60, 90 and 120 degrees. That is, it is placed in 30, 30, 30 in 3 positions. Okay. The AVL electrode is your left side, which is this one. It is here. All right. And here was your 0 degrees. That is your lead 1. We said anything above 0 degrees would be negative. What would be the difference between AVL and lead 0? Between AVL and lead 0, like these are 2 different leads. Correct. Very good. So this would be 30, because everything is, see, AVF and lead 2, 30, AVF and lead 3, 30. So this 30 degrees, but because it is above the axis above 0 degrees, so it is called as minus 30 degrees. Is it clear? Correct. So this is how we created the AVL system. How we got minus 30 degrees for AVL. Now when you see the extension, what we call the opposite of AVL. Opposite of AVL would be 30 degrees to lead 3 and it would become 150 degrees. It is not important, it is just for your understanding. Okay? And then you have the AVR. AVR would be 60 degrees away from AVL. Right? So this would become minus, so it would become minus 30 minus 60, which would become minus 90. Sorry. So this here, it is going backwards. This is you have to calculate it from the 180 degree mark, because this is minus, right? So this is minus 150. It was 0 degrees and you have to have a change of 30 degrees from your baseline. From your baseline you have to have a change of 30 degrees. So this is what you did and it became minus 150 degrees. Now there are two ways to do it. You can either just remember all of these values or you have an understanding of this. Remembering that AVL is minus 30 degrees, you might forget it at times. But remembering that AVL is above lead 1 and all these leads are at 30 degrees difference to each other would help you remember it as minus 30. You want me to use another color for which number? Okay, it's not visible. I'll use red. This is minus 50, this is minus 150 because of the difference from 180 degrees. Is this color better? Okay. And this becomes minus 30 degrees. Is that clear? Now, why are we so hell-bent on understanding all this? Is because of this diagram. If you look at this diagram, what we have tried to do is we have tried to map out the whole axis, and what we are going to do is we are going to have the cardiac conduction system. Okay, and we are going to place the heart according to all your electrodes. So here the electrode which is not visible would be AVL. Alright, I hope you understand what we are trying to do right now. So what we are trying to do is we are trying to place the heart according to all your electrodes. Is it visible? Axis diagram again. I think you'll understand it better through this diagram, Kolkata. What we are trying to do is, this was your 0 degrees, this was your 90 degrees, this became your minus 30 because it is looking the heart from the up above 0 degrees. This becomes your minus 150 degrees because it is 30 degrees to minus 180 degrees. Because this was 90, this becomes 60, because this is 0, this becomes 60, and this becomes your 120 degrees. Is it clear now? Do you get an understanding of what is going on? Okay. Now we understand a concept of vectors. What is a vector is basically anything which has a magnitude and has a direction. Okay, so it means that it should have a particular direction, like it flows from the west to the east, and it should have a particular quantity attached to it. So if you consider the cardiac conduction, it is actually a perfect vector. So when you say the cardiac conduction, it may be like for supposedly your right ventricle, the current flows into the right ventricle, right? And say you require 120 joules of electricity for a right ventricle to get activated. So it has a direction, comes towards the right ventricle, and it has a magnitude 120 joules. If a patient develops right ventricular hypertrophy, that is, he becomes more beefy and muscular, he would require 300 joules of electricity. That means the magnitude increased. There was an increase in the magnitude, and there is a direction also, it becomes more towards the right ventricle. So this is the concept of a electrocardiogram. An electrocardiogram will have a direction and it will have a magnitude. I hope this would get much more clear as we move along. That means it is trying to show you, one, that the electricity is moving from this end to the other end. Second, it's trying to tell you this is the magnitude at which it is moving. Is it clear? So P, Q, R, S, T are all expressions of the waves of depolarization. That is what we discussed, the sodium, potassium, your ATPase. You are masters of depolarization. You know much more depolarization than I do. But that is what you're trying to detect. When an electrode gets the current, it has a positive deflection on your EKG. When an electrode gets a current, it results in a positive deflection on your EKG. When an electrode has a current going away from it, it has a negative deflection on your EKG. This can be considered money. If you receive money, you become more positive, that is, you have a positive deflection. If you lose money, you become more negative. Is that clear? It's a very basic concept and it will help you everywhere you go. Is this point clear? How you get a positive spike, or you get a negative spike, how you get your T wave inversions, T wave, tall T waves, T inversions, flat T waves. This is how it is all being generated. Is that point clear? Kolkata, Goa, Nagpur. I'm waiting. All right, great. So when you understood this, so understand one more concept. So this is the concept of direction. Okay, this is the concept of direction. That means if it goes towards it, it gives to a positive spike. If it goes against, it gives to a negative deflection. Okay, this was direction. Now you understand the magnitude. When you consider magnitude, if it is 100 joules of electricity reach a particular area, it will give rise to one spike. If you get 300 joules, it will give to a big spike. Okay, if 100 joules goes away from that area, if 100 joules go away from that area, it gives to a negative deflection. If 300 joules go away from that electrode, it gives rise to a deep inverted deflection. This is the concept of magnitude. That is, more electricity goes, bigger your deflections will be. Very simple, very straightforward. When an electrode gets no money but loses no money, that means there is no positive gain or loss to that electrode. What does that electrode show? When you have an EKG, if this is your P wave, this is your something like a QRS complex, this deflection is called a positive deflection because it is net in positive. The QRS is in net in positive. Excellent answer, Goa. Excellent answer. When you have a negative electrode that is goes away from it, it will have something like this, which is a negative deflection. When the electricity is going at parallel to it, that means it is going in this direction, it will not have a straight line, but what it will have is a net neutral direction. That means it will have an equal deflection, that is the positive element would be equal to the negative element. It cannot be called a positive electrode, a positive deflection, nor a negative deflection. So to assess the directions, you have these three main ways it can have a deflection. It can either go up or it can either go downwards. Is that clear? Now we come back to our final thing that we wanted to understand about the EKG, which would help you take home with you what we are trying to assess, how we are going to have the answer finally. So once you developed your axial system, you have the AVL here. Okay. Now please pay attention to the animation here. It is a very important animation, and it is based on the concept which you very well know, that the depolarization current will start from the SA node, will go to the AV node, and then it will go downwards. When it goes downwards, as we said, it should have a magnitude as well as a direction. Now direction wise, it will go into the right ventricle and also in the left ventricle. But magnitude wise, because the left ventricle is so much bulkier, so much beefier than your right ventricle, a lot of the magnitude would be towards the left side. So when you draw a net current, that is a net positive and negative, the net direction is more towards the left. It is more towards the left because of the excess magnitude of that current towards the left. Okay, towards your left ventricle is your leads 1, 2 and AVF. As you can see from the diagram, it is 1, 2 and AVF. AVR is placed upwards and lead 3 is to the right. The basic concept of an axis is wherever the current flows to, that lead will become positive. Wherever it flows away from, there it will become negative. This is the basic concept. When you start the electricity, it goes from the SA node and down towards the lead 2 and lead AVF. That is because those are the leads which are facing your left ventricle. I hope this is clear. When you had the current, when you placed it, the current started moving from the SA node downwards up to your lead 2 and leads AVF. So the leads which are going to have the most positive deflection should be lead 2 and lead AVF in a normal person. Is this point clear? Everyone, we can wait here for some time. I hope this drives home the point of an axis. Great. So this is how we are trying to we develop the axial system across the heart. We placed electrodes everywhere and we are trying to map where the electricity flows from left to the downwards to the right. Now we will draw it into an axis. So if someone asks you tomorrow, what is the normal axis of the heart? Okay, the question is very straightforward. What is the normal axis of the heart? The normal axis of the heart 2, but it is always going to be in a range. So anything that is between 1 and lead AVF, more so indicates that it is towards the left side. Till the time it's towards the left side, we say it is normal. So from 0 degrees to 90 degrees we say is the axis of the heart, and 60 degrees, which is your lead 2, is the most common direction of the heart. So whenever you see the EKG strip, the most positive electrode from the 6 different electrodes, that is your frontal electrodes, your limb electrodes, which is your 1, 2, 3, AVR, AVF, AVL, which would give you the axis. If it is the tallest in lead 2, that means it is a normal EKG axis. That's a normal EKG axis. So this is again to highlight what we are trying to say. So if it is starting from AVR and going in the opposite direction, what should be the net electricity in AVR? Should it be a positive deflection or a negative deflection? Correct. So it should be a negative deflection. Nagpur says positive. Why? See, if we are talking about AVR, the electricity is going away from AVR towards lead 2. So it should always be negative. We said if someone takes money from that electrode, takes away from that electrode, takes money away from you, you will become net negative. That is what is happening with the AVR lead. Why it is important is because there is a very simple cardiac condition called as ventricular fibrillation and ventricular tachycardia. Basically any ventricular rhythm. What the question I asked was, what would be the net deflection in your AVR electrode? What should be your net deflection? You need to answer that, Kankinada. Correct. So, because it is going away. In what condition would it become positive in AVR? It will become positive in AVR when this current is flowing in the opposite direction. That means it is starting from the ventricle and it is going upwards to the atrius. Such a condition is called as a ventricular rhythm. Such ventricular rhythms are either a ventricular tachycardia or a ventricular fibrillation. So extreme axis, that is positive in AVR, that is minus 150 degree axis, would be present in ventricular tachycardia or ventricular fibrillation. Now that you've understood what is happening and how it is happening, I will help you realize how we are going to diagnose such conditions. So we'll have a very simple way of diagnosing EKG axis. I don't want you to memorize it. I want you to understand what we are trying to do. As we said, we have mapped out the heart into 30-degree axes. Okay. Our normal axis was 0 to 90 degrees. Anything that is in this area is a normal axis. So these two form our boundaries. I'll repeat, anything between 0 and AVF, lead 1 and AVF are our normal. So these two would form our boundaries. And these are the only two electrodes which we are going to look at. These are the only two leads we are going to look at. Lead 1 and lead AVF. If an electricity flows towards lead AVL, if it flows towards AVL, it is also flowing towards lead 0, right? In this quadrant, it is actually flowing towards lead 0. Lead 0, this is the area of lead 0, right? So it is flowing towards lead 0. But it is flowing away from lead AVF. So here it would become positive in lead 1 and negative in lead AVF. This condition No, no. It is just for the diagram sake that it looks like that. Lead 3 is not the opposite of lead AVL. No. Lead 3 was 90 degrees. We just talked about it, right? There's just different axis systems that have happened. This was your 120 degrees and this is minus 30 degrees. So when it is going in the opposite direction, it would be positive in lead 1, but it would be negative in lead AVF. So when it is negative in lead AVF, so when you looked at it, you just looked at two electrodes, you saw lead 1 is positive, lead AVF is negative. You understood this is going away from lead AVF but towards lead 1, and there is only one quadrant like that, and it is this quadrant. And this is called as a left axis deviation. Anything above 0 degrees, that is minus whatever, is left axis deviation. So anything up to minus 50, minus 60 is left axis deviation. Now you looked at a scenario where it was negative in lead 1 but positive in lead 90. That is your AVF lead. So this comes to this quadrant. It becomes this quadrant. If it is positive in lead AVF but negative in lead 0 degrees and lead 1, that means it is going away but towards AVF. Such a condition would become a right axis deviation because it is more towards your right side of the heart and the other one was more towards your left side of the heart. So that becomes left axis deviation and this becomes right axis deviation. The last scenario is it is negative in AVF and it is negative in lead 1. So that becomes this quadrant of the heart and this becomes your extreme axis. And we just spoke it can happen only in anything that can go in the opposite direction. Okay, it can only happen in this condition. This is what I'm trying to talk about. So I'll repeat it right now. I'll sum it up. So we are just looking at two axes. One is your 1, which is 0 degrees. Another is you're looking at 90 degrees, which is AVF. If it is in positive in both, that means it is in this quadrant, this particular quadrant here. Okay, it's already shaded. So it becomes 0 to 90 degrees. But if it is negative in this one, that means it is going away from 90 degrees. But it is positive in 0 degrees. So it is towards 0 degrees. So this becomes this axis. And this particular area will be your left axis deviation. When you are considering it is negative in 0 degrees, that means it is going away from 0 degrees. And it is positive in 90 degrees, positive in AVF. Yes, it is the current flow direction. So, and it is positive in 90 degrees. So this becomes your right axis deviation. And the ultimate one becomes your extreme axis deviation, which is negative in both. So that is the complete vector and how it is coming positive in whichever area it is. Is this clear? Great. Now look at this EKG and try to answer what the axis is. I'll wait for all of you all to answer. There's no point moving ahead if you can't understand this axis thing. I just got answers from Kolkata and Kankinada. What? Kakinada. Okay, so then it's written Kankinada. I'm sorry about that. Alright, so great. So what we try to do is we try to see lead 1 and we try to see AVF. Both are positive. That means when I drew this the thing here, it would be in this quadrant. That is 0 is also positive and AVF is also positive. And this quadrant was our normal. So excellent, everybody who answered normal. It is 0 to 90 degrees. We are not concerned how much exactly it is for your step examinations. It is not asked what is the absolute axis. That would be a bit more difficult and bit more redundant. Please answer this one. Correct. So it is right axis deviation. Again, we have 1. This is a negative deflection. This is how a typical negative deflection would look like. Lead AVF is a positive deflection. So when you draw the axis diagram, it would be something where the 0 is negative. See, if it is anywhere on the left side, the 0 would never be negative. So this half, it cannot be here. It has to be on the right half. Getting it? It cannot be in the direction of 0 degrees. 0 is on the left. It cannot be on the left side. So it has to be on the right side. And it has to, if it cannot be here because this axis here, oops. Because this axis here is this. Because it is negative for 0, that means it's on the left side, and it is positive for AVF, that means it has to be on the bottom side. If it is on the top side, yes, you need to look at the QRS, because see, the ventricles are the most predominant musculature of the heart. So they will dictate the axis of the heart. Atria, the P waves, would have an axis of their own, but it is not very important. When you say the axis of the heart, you're talking about the axis of the ventricles. Okay? So I hope this is clear. So I'll just make it simplify it a little bit for the people who are not participating. When you are seeing this as a heart and with the various axes, you have divided it into quadrants. The 0 degree represents your left quadrant, left side of the quadrant. Lead AVF determines the bottom, down side, down. Okay? Any axis any current which is going towards the down would be positive here. Alright? Anything which is going up will be negative in AVF. This point is clear. So AVF determines the down, bottom half. If it is moving towards the bottom half, it is going to be positive. It is going towards the upper half, that if it is going in the minus angles from the 0 to minus 180 degrees, that would be negative for AVF. Similarly, when you're calling it, when you're talking about 0 degrees, it represents the left side. Anything that is present on the left side would be positive here, and anything which is present on the right side would be negative here. Alright, so this is how you generate the axis. So when you say it is positive in both, That means to be positive on the left side for the lead 1, it should be on the left side. And to be positive for AVF, it has to be on the bottom side. So there is only one quadrant which it can be positive, and it is your normal axis. When you say it is right axis, as it is right, it cannot be on the left side. So the leftward would be negative. The demonstrator of the left side, which is lead 1, is negative. So lead 1 will become negative and it would be on the downside. So AVF would stay positive. So this half would become, so this is your right axis deviation. When you say AVF is negative, that means the angle is going upwards. The direction is upwards. It is in minus degrees. It is not in plus. If you say A1 is positive, that means it is on the left side. If you say 1 is also negative, then we say it is on the right side. Is this clear now? So now with this idea, you can easily answer this question. It looks tricky, but it is one of the simplest rhythms to decipher. First answer, is it lead 1? First say, is it positive or negative? Then say lead 2, is it positive or negative? And then you get your answer. Correct. So I've got 4 correct answers. So see, lead 1 is negative and lead AVF is negative. So when both are negative, that means it is on the right side, but it is not on the bottom. It is going upwards, and there is right upwards is extreme axis. This. It's a bit tricky. Yes, very good. That was, so this is ventricular tachycardia. When we said that the rhythm is originating from the ventricles. Any rhythm which is originating from the ventricles would be called ventricular rhythm, and as it has extreme rates, it is called ventricular tachycardia. I want you to answer this question. Poona, okay, I got one answer. Correct. So this is a normal axis. This is a normal rhythm. So this is a positive deflection because there is net positivity. It is not in negative. So don't, it is not the size of, which is the absolute size. Your Eluru. Okay. Why is it, my screen shows your Pune. There was no way I could understand. So this would become your, so your AVF is also positive. Is that clear? I hope by this point, which table? I want you to draw that table on your own, Mangalore. It is a very simple table. You can easily draw it on your own. You had this. I said if it is on the left side, it is 1 positive. If it is below, it is AVF positive. Now draw it according to yourself. It's not very, very difficult. If it is going downwards but to the right, it would become right axis deviation. If it is going upwards but to the left, it would become left axis deviation. Correct? Satisfied, Mangalore? S means yes or no. If you have this, okay, great. So this becomes your right axis. Now we were talking about, so the way I have structured this talk for today is in a way so that we can ease you into the whole process. So if you see the theory of it, condition which would cause a right axis deviation and a left axis deviation. Anything which would make the right side of the heart more predominant. That means if there is right ventricular hypertrophy or there is some conduction block which is changing the vector in a manner that it is more towards the right, will lead to a right axis deviation. Common causes would be a right bundle branch block, the right ventricular hypertrophy conditions like pulmonary artery hypertension and cor pulmonale. Left ventricular deviation, left axis deviation is mostly electrical abnormalities like left bundle branch block, because normally left ventricular is already the predominant muscle. So muscular hypertrophy is a less common cause of left axis deviation. Okay, this is what you have to remember: right ventricular hypertrophy and right bundle branch block. For RAD, for LAD it can be left bundle branch block, or mostly left bundle branch block would be the predominant condition, or if the patient had some prior complications like MI which resulted in a left bundle branch block. So now we'll be moving on to EKG rate. So there are very few things that you need to understand before we go to the EKG rate. One of them is, when I said about the EKG axis, what we were trying to do is we were trying to photograph the heart, right? When you are trying to understand the EKG rate, you need to understand that there is something called as a stylus. Okay, there's something called as a stylus which will keep moving with my heart. So as it detects some electrical activity in the atria, it will deflect up and go down, and then it will form a flat line, and then it will drop and go form up and down. So this is the basis of the movement of the stylus. And what is it moving on? It is moving on the sheet of paper. The paper beneath it is the one which is moving. It is not that the stylus is moving ahead. Stylus is at the same place. It is the paper which is moving. If I increase the speed of the paper, the stylus will cover more amount of paper. If I decrease the speed of the paper, the stylus will cover less amount of paper. Is it clear? So if this is the stylus and this is the paper, and stylus is this way and the paper is moving ahead, the stylus is constant. I keep it at 25 millimeters per second, so it moves to 25 millimeters in a second. If I keep this at 100 millimeters per second, it will move to 100 millimeters in that second. The stylus is the same, but the paper has changed. Okay. So when you say a single speed EKG, double speed EKG, this is what you mean. So when I have to compare, because my stylus is like this, in a 25 millimeter, it will go and move like this. But when you increase the speed of the EKG paper, it will move much more. And it will space out and look like this. So this is a 25 millimeter per second EKG, and this is a, say, 50 millimeter per second EKG axis. Charger. This is a 50 millimeter per second axis. So this is what you need to understand about the EKG machine. When you say a normal rhythm, a normal speed of the EKG is 25 millimeters per second. It is 25 millimeters per second. The EKG paper is made such that it is built up of boxes. Everybody has used a graph paper in school, and a graph paper basically has what? It has a large box and it has small boxes. So it is the same graph paper that we are going to use in a EKG machine. We have a large box, and each large box is made up of 5 small boxes. It's conceptually correct, not mathematically. It's an illustration. So this large box here will have 5 small boxes. Is it clear? Each large box is 5 millimeters. This is what it says. Each large box is 5 millimeters. And a normal speed of an EKG is 25 millimeters per second. So in 1 second it moves 25 millimeters. That means it moves 5 large boxes. Clear? If it moves 5 large boxes in 1 second, how many large boxes will it move in 1 minute? Right. So it would be 5 into 60. Simple maths. So in 1 minute, it will move 300 large boxes. Each large box is made up of 5 small boxes. That means it will move 1500 small boxes. Is this clear? Because later on, when you'll have these numbers, I don't want you to memorize them. Memorizing is not a thing doctors do. Doctors understand the concept. Right? If you want to excel, I think so, you need to understand the concept so that it lasts with you for a long period of time. You can tell it to your grandson and great grandsons how the 300 and 1500 concepts move along. Okay? Because the heart, a normal pulse is 72 beats per minute. Right? So in a 60 seconds, it is quite huge. The number is about nearly 1 or 1.25. So when you're calculating things on the EKG, you have events which are occurring faster than 1 second. 72 beats per minute would be 1 beat in almost 0.8 seconds. In 1 beat, you have your P, you have your Q, R, S, and you have your T. So everything would go into decimal places. To prevent this decimal places, we talk in EKG on the basis of milliseconds. So again, 1 second is 1000 milliseconds. 5 large boxes were covered in 1 second. That means 5 large boxes were covered in 1000 milliseconds. So 1 large box is covered in 200 milliseconds. And 1 small box would be in 40 milliseconds. And so this is how it is calibrated. So once you become a cardiologist, you will read up more and more how a P more than 40 milliseconds means it is P mitral. So that 40 milliseconds, it's not that he's taking a inch tape, he's just seeing it on the basis of a small box. If it is wider than 1 small box, he says this is a dilated P wave. You don't have to remember all that, but you need to remember why we have milliseconds in EKG. So this is what we were talking about. So 1 large box, which is 5 millimeters, would be 200 milliseconds, and 1 small box would be 40 milliseconds. A pulse, one cardiac beat is between 2 systoles. Dhap, dhap. This period is the between 2 systoles. That means it is between 2 RR intervals. So when you calculate, when you talk about a pulse, one pulse, that is the time between two RR intervals. The number of RR intervals that occur in 1 minute would understandably be your heart rate. Correct? That means the number of pulse that you have in a minute is your heart rate. Simple. So heart rate was how many boxes? It was 1 minute, right? 1 minute. 1 minute means 300 large box. It means 1500 small boxes. Crystal clear. That means number of RR intervals that would occur in 300 minutes would give you your heart rate. So that would be 300 divided by RR interval. Getting it? You'll get it this way. So what was your pulse is basically the RR interval. You want to know how many RR intervals occurred in 1 minute. That is what you want to know. If you say that for one RR interval, it took you 6 large boxes. For one RR interval, it took you 6 large boxes. How many RR intervals will occur in 1 minute? 1 minute is equal to 300 large boxes, which would be 50. I hope you get how we got here. So, correct. 1 RR interval was 6 large boxes. You have 300 large boxes to traverse. How many RR intervals would be 50? Each RR interval is a pulse. So how many, what is your heart rate? Is 50. Very simple, very clear. Is it clear? I have written the math. So it is 300 divided by the number of large boxes between the RR intervals. If you are noting it down and you plan to go home and cram, it's not a very good idea because everything is in front of you. RR intervals signifies one systole. If one systole takes 3 large boxes to happen, one systole took 3 large boxes to happen, how many systoles will happen in 300 large boxes? Simple, 100 systoles will happen. Correct? This is your heart rate. Is it clear? Rest of the crowd? Eluru, Nagpur, and rest of the company. Okay. So you have to remember that you have to calculate the number of large boxes in between RR intervals and divided by 300. Okay, that is 300 divided by number of large boxes. For your EKG for an advanced level, or even when you are appearing for your steps, because the time allocated per question is going to be very less. We'll have a trick for this, like we had a trick for the EKG access. What we have here is 100 and 60. These are the two numbers you need to remember. Anything between 100 and 60 is a normal rate. Right? More than 100, Amritsar stuck. Fresh. Refresh. So we were talking about the hack to diagnose, to understand the rate faster. You had 60 to 100. That is your normal rate. 60, less than 60 would be bradycardia, more than 100 would be tachycardia. If there are 3 large boxes between an RR interval, you know the rate would be 300 divided by 3 would be 100. If there are 5 large boxes, you know it would be 60 because you will divide it by 300. So anything between 3 to 5 large boxes would be a normal rate. It is not tachycardia or bradycardia. So first count the number of large boxes. If it is less than 3 or it is more than 5, only then worry about the rate, or you can move ahead to your next thing. Is this clear? Okay. So now we'll be moving on to the final element of EKG before we will go to the particular topics, that is understanding of the EKG rhythm. Now, why we need to have this understanding is EKG, like any of the imaging studies that we do, like the X-ray or CT scan, radiographic scans, you need to be well versed with a particular pattern. If you have a rhythm, if you have a system to evaluate it, you can never go wrong. If you understand the axis needs to be assessed in this manner, you see a left axis deviation, you don't have to rely on the criteria for ventricular tachycardia. You can just say that this is fulfilling my extreme axis and it is most likely originating from the ventricles, and that's why I'm calling it the ventricular tachycardia. This is how it helps you. So always when you have an EKG, even today in the class, whenever we are evaluating an EKG, what we'll be doing is we'll be going through the rate, rhythm, axis, and only then we'll be talking about the particulars, so that you always have a habit of not diving into what is jumping right at you. First you try and understand how we can approach it better. When you're talking about the EKG rhythm, when you see the heart, you have this. And then you have the T waves. Now I'll be talking a bit about how we named them. P wave is characteristically the atria. And it is the atria that you see through the P wave. So it denotes atrial activity. Then you have the QRS complex. QRS complex is your ventricular activity. That is your ventricular activation and deactivation. That is what it signifies. And then you have the T wave, which is ventricular repolarization. T is repolarization. Now, when the various waves were being named, it was by convention. When you say convention, there is no particular reason to call it the P wave. It is just a convention. Just like 0 is called 0 for no reason. It's a convention, right? So that anywhere across the globe, everywhere it will be called the P wave and the QRS complex. The Q wave is the first negative deflection that happens before the positive deflection of the ventricle. First negative deflection occurring before the positive deflection of ventricle is called the Q wave. Any positive deflection from the ventricle will be called the R wave. Any positive deflection from the ventricle will be called the R wave. Any negative deflection from the ventricle following the R wave will be called the S wave. This is a convention. Is it clear? So when you're talking about the rhythm, what we are trying to know is, does it originate from the SA node, go to the AV node, goes down through the AV node, through the bundle of His, into the Purkinje fibers, and then into the right and the left bundle. This is what we call as a sinus rhythm. I just want to make sure everybody is aboard. So can you just type your presence? Okay, thank you. Great. I was just concerned I've lost some of y'all. So we have the sinus node, and when it goes from the sinus node downwards, this is called as the sinus rhythm. So any rhythm where the P wave is followed by the QRS, that means the atria contracts and then the ventricle contracts, is called as a sinus node. If there is no P wave, there is only the QRS complex, this means that it is starting from this area, that is the bundle of his Purkinje fibers. It is starting from this area, and this would be a junctional rhythm or a ventricular rhythm. This can be anything but a sinus rhythm. It is not starting from the sinus. So the area where the rhythm is starting is called that type of area. You guys are physiology people. You understand biochemistry and physiology way better than I do. The only reason the SA node dominates the heart rhythm is because it fires at a faster rate. The whole cardiac musculature has its own automaticity. What that means is, if I take a part of the heart out, and the rest of the myocardium will still keep on contracting. That's why when the SA node fails, the AV node takes over. When the AV node fails, the bundle of His takes over, and then the Purkinje fibers take over, and then the ventricles take over, which is called as the idioventricular rhythm. It is very important from EKG point of view to understand what is driving the rhythm. If whatever is driving the rhythm is the main culprit, and that is why we need to understand that. So the first thing first, that means first thing that you see for an EKG rhythm is the presence and absence of a P wave. If a P wave is present, that means there is an SA node which is active. The second thing that you're going to see is the PR interval, that is, there is a P and then there is an R, and this interval, that is the PR interval, is constantly present. It may be after some time there is again a PR interval, and you see that there's a PR interval is constant. That means all your QRS is driven by the P wave. There might be certain conditions where the P is contracting way different to the QRS complex, and there are multiple P waves here which are very different from the QRS complex. What that means is QRS is contracting at its own rhythm and the P wave is contracting at its own rhythm. So QRS is regular. This regularity will tell you that this regularity will tell you if it is a problem. If it is irregular, you'll come to know that there are some conducted beats, there are some beats which are not being conducted, or there is some form of heart block. Our question is, if there is no P wave, is it junctional or is it ventricular rhythm? The thing is, once you see that there is no P wave, it can either be a junctional or a ventricular rhythm. We'll get to it in a moment. So when you are seeing the PQRS complex and you say that the P is prolonged and then there is the QRS complex, that is a PR interval is prolonged, and this is called the first degree heart block. That is, this area, this part is endangered. That is, there is some defect at SA and the AV nodes. So this is called as the first degree heart block. Okay. If the P waves are contracting on their own and the QRS is contracting on its own. Then there are a lot of P waves in between, and then there is again a QRS. That means there is no synchrony between the QRS and the P waves. This is called as a complete heart block. Complete heart block would be when the heart, the chambers, this is contracting on its own and this is contracting on its own. There is no conduction across the atria to the ventricles. This condition is called as a complete heart block. Now, whichever part of the heart is going to generate its rhythm, it's going to have its specific morphological feature. Whichever part of the heart generates a rhythm is going to have its specific morphological feature. If this heart starts from the junction, what do you mean by the junction is, it is this part. This part is the junction. That is, it is not starting from the ventricle. It is starting from the atria, but from the SA node or the bundle of Hess. If it is this part, that means the QRS complex is narrow, less than 120 milliseconds. If it is starting from the ventricle, this is wide, that is more than 120 milliseconds. When you are talking about the QRS complex, you are talking about this complex. What this means is the electricity being conducted down a conduction system or is it being conducted down the muscles? What we are trying to understand is the conduction occurring through the muscles or through the fibers. If it is through fibers, that is your conduction system. This is fast conduction. Whenever it would be a fast conduction, that means the electricity zoom just moves into both the ventricles. It is like electricity which is coming to your houses through the wires. So that is a fast electricity, and there the conduction would happen quickly. Is this clear? But when it is happening through the muscle is a poor conducting system. And this would be slow conduction. Slow or very slow conduction. And this would result in widened QRS complex. This is wide QRS. Is it clear? So if it is from the junction, when you talk about the junction, you are talking about the bundle of Hess or the AV node. It will still be through the bundle branch. It will still be through the bundle branch that the electricity flows to the ventricle. So it would be a narrow complex, and it would be a wide complex QRS if it is through the muscle. Is this point clear? Kolkata? Okay. Now we are moving to a very interesting, but albeit it might take some time to understand. It's a simple concept, the concept of bundle branch blocks. It is very important because it's a very important differential for almost all types of cardiac rhythms. Something called as a bundle branch block. What do you mean by a bundle branch? What do you mean? So let's just try and understand how a normal electricity transmits. I have the SA node here and I have the AV node here. electricity flows from the SA node down the AV node. This gives rise to the P wave, and this is the PR interval. Okay, this is very simple. Both the atrias are very thin. They are almost similar to each other. So the activation of both the atrias happen simultaneously. Because it happens simultaneously, you just have one P wave. Just like the S1 sound, which we'll see subsequently, is a single sound. It does not happen, it does not have a aortic component and a pulmonary component. It is a single sound. Similarly with the P waves. When it starts to move down the bundle of His and then into the Purkinje fibers, this is basically in the ventricular septum. This is in the ventricular septum. This septum gets depolarized from the left to the right side. The basic vector that depolarizes the septum is from the left to the right side. Is it clear? Because the left-sided conduction has a greater magnitude, there has to be more amount of current that goes down the left side, right? Because of the bigger musculature. So it is always left to right. But when the ventricles start getting activated, ventricles, the net current is from right to left. The net current is right to left. This is because the left ventricle is the beefy, fat ventricle. It requires more current and it requires more time. So the magnitude is more and time required is more. So the vector moves from right to the left side. Is this clear? Okay. What we are talking about now is that we had 6 electrodes which we did not talk about when we were talking about the EKG axis. We said these are your locators. These are your prime importance when you're talking about the specific activity which is happening inside the heart. They are more important as far as the localization is concerned, and these are your from right to this extreme left, which is your precordial leads. So having this concept in your mind, what we'll do is we will make a general idea. So when we talk about the lead V1, is it visible? When we talk about the general V1 and we talk about V6, V1, use white, okay. So when we are talking about V1 and we are talking about V6, what we are saying is V1 is looking at the right side of the heart and V6 is looking at the extreme left side of the heart. This much is clear, right? We'll get to that, Pune. What we are talking about is V1 is looking at extreme right, V6 is looking at the extreme left, right and left in the axilla. The septum, because of the magnitude that is required for conduction, would be left to right. It would come from left to right. First thing in the ventricle that gets activated is the septum. It will come to the septum, then only it can go to the right and the left ventricles. The septum is a thick wall of the ventricle. So first thing to depolarize is the septum. The first deflection that would be seen in the QRS complex is the septum. After the septum, the ventricles will polarize from the right to the left side. Okay. Now understand this. Now this is your left ventricle, and this fat thing is your right ventricle. This is your right ventricle, the thin one, and this is your fat left ventricle. As both start contracting, the overall activation of right ventricle and left ventricle start together. The depolarization of left ventricle and right ventricle start together, but the depolarization is complete of right ventricle earlier than left ventricle. The depolarization starts together but completes earlier on the right side and later on the left side. Is this clear? Now, forget about the P waves. When we were talking about the money principle, anything that comes to the lead is positive. Anything that goes away from the lead would be a negative deflection. When you are talking about lead V1, the electricity starts flowing in lead V1, right at the Purkinje level. The septum starts getting depolarized, and it gets depolarized from the left to the right side. Left to the right side. So the first deflection that is going to happen in lead V1 for the ventricles is a positive deflection. There is not going to be a negative deflection in V1 because the septum depolarizes from the left to the right. After that, as the electricity moves downwards, now the right ventricle and the left ventricle are started to depolarize. But the left ventricle dominates so much area of the heart that the right ventricular depolarization is not detectable unless there is an abnormality. So normally it is just not detectable. So as the ventricular depolarization now will happen from right to left, that is, they are going to lose the money. It will be followed by a negative deflection and then come back. So a normal ECG, whenever we are talking about it, this is what you're going to find. This is what you're going to find in an V1 electrode. This is called as an RS pattern. This is a convention that anything that is following the R wave will be called the S wave, not the Q wave. It's a convention. Otherwise it would lead to a lot of confusion. And so it is denoted as the RS pattern. What this means is the R is a smaller deflection, S is the more dominant deflection. Now with the same principle, when you move downwards, when you go to the left sided lead V6, the first thing that happened there was electricity went away from V6. When it goes away from V6, there is a negative deflection. But V6 is going to have majority of the chunk because the ventricle will now depolarize from the right to the left side, and this would be upwards. This is the upward deflection which will go here. As the depolarization is happening, there are certain parts of the left ventricle itself which do not depolarize together, and these lead to a negative deflection later on, which is called as the posterior septum, which will be asked in your anatomy and all those things, which is the part of the septum which depolarizes the last, and this is the part which leads to the S wave. So here you have your characteristic QRS complex. That is your QRS complex. So V1 and V. So all the leads between will just be transitioning towards V6. That means the R wave will become bigger and bigger, the S wave becomes smaller and smaller, and this is how it is going to transmit. S wave demonstrates the areas which depolarized the last. Why do you want to wait? Don't jump ahead to the magnitude. We are not deciding upon the magnitude right now. If you're asking how we decide the R and S magnitude, that is just relative. Like this would be 2 small boxes, this is 5 small boxes. So there's the S wave is the larger wave. So that is how you determine the axis. It is relative to each other. So yes, this will be a small q because this q is much smaller than the R, right? You can write it as a QRS complex. This is how you write it. But we are not talking about longer. We are talking about which one is taller. The answer is taller. And you can see it by the boxes. You can see it by your naked eye, right? Can't you determine which one is taller in R and S? Amrit sir? I mean, by your naked eye, you can determine which one is taller, right? From your R and your S wave in V1 and in your Q and your R waves in V6. Yes. So this is how you are going to do it. You can simply see it has to outstand. You don't have to take a scale. You will never find a cardiologist with a scale anywhere. Okay. When we are talking about the septum depolarizes from the left to the right side. And the ventricles depolarize from the right to the left side. Why does the septum depolarize from the left to the right? Because the left bundle is going to go a long distance. It has greater magnitude, so it will have more influence on the septum. It will provide more electricity to the septum, and the septum is the first thing that gets depolarized. When you see, look at the heart from an outside view, this is how the heart is, right? So this is your SA, this is your AV, and this is where? This is in the septum. This muscle here is in the septum, right? And it is the septum where it has the bundles and everything. So this part, bundle of hairs, is present in the septum. This is the first thing that is going to get depolarized is the septum. Whenever electricity flows towards an electrode, it becomes positive deflection. Septum is left to right. The right side electrode will get excited and it will have a positive deflection. The magnitude of this deflection would be the magnitude of the electricity septum requires. After that, there would be the ventricle. The ventricle depolarizes from the right to the left, and the magnitude of the ventricular depolarization would always be much higher than the septal magnitude. And as it is going away from V1, it will lead to a negative deflection. Any positive deflection after P wave is called R. Any negative deflection after after R wave is called as S. So this is called as an RS complex, and this is how it should appear in V1. Leave apart the nomenclature for now. That why you call R small and S big. That is all a different story. But you should remember V1 is this. There should be no Q wave. There is R wave. There is S wave. Okay. When you consider the left-sided electrode, the first deflection was the septum, which went from left to right. As it went from left to right, the first deflection would be a negative deflection. But this is the septum, so it would be less. Then the next one would be a ventricular, which would be a massive contraction, which would be the R wave. After that, there is some proportion of the left ventricle which does not get depolarized along with rest of the ventricles, and which leads to a small negative deflection. This small negative leads to S wave. This is called as the Q wave, and this is the R wave. This is how a normal ECG will look like. Is this clear? Okay. Now, the important concept of bundle branch blocks. If there is a right bundle branch block, the septum was getting depolarized thanks to the left bundle. So now, because the septum is getting depolarized thanks to the left bundle, left to right would be normal. Okay, a right bundle branch block, left side is functioning normally. So left to right would be normal. So the first deflection, which was positive in this condition, will stay positive in V1. But now there would be a twist in the story. The ventricle was depolarizing from right to the left. The ventricle depolarizes from the right to the left. This is because of what? This is because of the conducting fibers. The conducting fibers which were present, this was your right, this was your left. Electricity went both ways. Because for this it had to go a long time, it was left, right to left. But now, what? Kakinada. It is right to left when the septum goes. That is because the right is a smaller branch and the ventricle requires less time to depolarize. But if there is right bundle branch block, that means this block is here. How would the ventricle activate now? After the left ventricle has activated, it will start to conduct via the muscle. It will conduct via the muscle. Muscle conduction is very slow. Getting it? Right sided, there is no bundle now. So all the conduction will happen because of the left bundle. So where is the vector headed now? Now the vector is headed from the left to the right. This is where the bundle is headed now. So in case of right bundle branch block, the ventricular depolarization, rather than right to left, it will now become, rather than right to left, it will now become left to right. So what will happen now? The septum contracted, septum got activated. Now the left ventricle will get activated before the right ventricle, which is opposite to the normal physiology, because now the left ventricle is getting conducted to the conduction fibers and then it is conducting to the right ventricle. So this goes into the normal negative deflection that we expected. The normal negative deflection is because of the left ventricle. But after the left ventricle is activated, what will get activated now? The right ventricle. So the current will now come from left to the right side, and this will result in a second positive deflection. So the earlier RS pattern now becomes RS R dash. Some would call it the M pattern. Don't worry about the M and the W pattern. When you are seeing at the right bundle branch block. So first basic concept I want you to have very clear is the LV activation. So the LV muscle and the RV muscle is this way. This is your right ventricle and this is your left ventricle. Whatever happens, LV will have an impact on the EKG. LV will not disappear. RV can disappear. RV is this big. LV is this big. It is 3 times bigger. So LV will always have an impact on the EKG. Don't get confused where the S wave come from. Whenever you're talking about the EKG, LV will be there. If there is no LV in the EKG, the patient is dead. Because it is my left side, I believe. 2 ventricles opposite, I didn't get that. Can you elaborate on that? Kolkata. That is just for understanding, but it is labeled, right? Is it clear better now? So the LV is much bigger than the RV. Okay? The point I'm trying to make here is, see, you have to try and understand this concept that whatever happens, the LV is not going to disappear from the EKG. That is what I'm trying to help you understand. So when you are seeing the left bundle branch block, the right bundle branch block, though the ventricle is depolarizing from the left to the right, the LV will have an impact on the ECG. And when LV gets activated, for the right side, it is always going to be in the opposite direction. When it is in the opposite direction, it will be a downward deflection. But because the RV is getting activated from the musculature, as it is getting activated from the musculature, it would be slower. And as it is slower, it will happen after the LV contraction and it forms a positive deflection. Is it clear now? So when you have a left bundle, when you have a right bundle branch block, when you have a right bundle branch block, what this means is that the electricity has to flow from the left side to the right side. Is this clear? Nehru Nagar, Kakinada. The electricity has to flow from the left side to the right side. This electricity conduction will happen through the muscles, because it cannot happen through the conduction fibers, because conduction fiber is blocked. When electricity is conducted through the muscles, it is slow, very slow. Okay? When it is very slow, it will contract, it will get depolarized after the left ventricle gets depolarized. Okay? When the left ventricle gets depolarized, during that time, the electricity is flowing towards the left side, right? So first, the electricity was flowing towards the left side, and after that, the electricity was flowing towards the right side to activate the right ventricle. Is this much point clear? Okay. So first when septum gets deactivated by the left bundle like normal. Then the left bundle goes down, but the right bundle does not go anywhere. Left bundle activates the left ventricle, and by the time left ventricle started getting activated, some of the electricity started flowing through the muscle to the right ventricle. Then gradually the right ventricle got activated. Okay. In V1 is the right-sided lead. V1 is right-sided lead. So first was the septum, which was normal. After the septum, what got depolarized? Left ventricle. Left ventricle is the big daddy. Left ventricle is the big brother on the EKG. It always has an impact. Left ventricle, when it was getting activated, where was the current flowing? Towards the left side. When the current is flowing towards the left side, that means it is in the opposite direction for lead 1. Anything that is in the opposite direction gives a negative deflection. So you get a negative deflection, which is just as in case of the normal heart. What happens in a normal heart is, during this period only, the right ventricle gets depolarized and gets finished. Because we saw that right ventricle is this big and left ventricle is this big. But in this case, the right ventricle is now getting depolarized. Because it was a conduction block, right? And the conductions are happening through the fibers, through the muscle, not through the conduction fiber. Because of this, it gets activated slowly, and now where is the conduction happening? It is happening from the left side to the right side. As it is happening from the left side to the right side, it will result in a positive deflection, and there you get a positive deflection. Whatever is a positive deflection in a QRS complex can only be called an R wave. We cannot call it anything else. So we call the first R. This is the S, and this becomes called the R dash. R dash means looking like an R wave. Is it clear now? Nehru Nagar, is it clear? Kakinada. Okay. So this is the concept which is happening in the V1. Now we'll see what will happen in the left-sided leads. V6 is the left side lead, right? First deflection in V6 was because of septum. Septum is still going from the left to the right side. So it will be negative. What happens now is, when you are talking about the LV and the RV, this is a thin LV, this is your thin RV, and your thick LV and RV. And my lead is placed over here. This is my lead, and it is attached to a wire. Because it is placed in the left axillary region, it cannot visualize right ventricle very well. This is a very important point. It cannot visualize the right ventricle very well. Even if the right ventricle is contracting slowly, it cannot look at it very well. So here the predominant would be again the big daddy, the left ventricle. The left ventricle is being activated. After that, what happens here is, there would be an S wave. This S wave would be deeper. Like there is a normal S wave in normal EKG. This S wave will be deeper. A deep S wave would be present. This deep S wave is because of the RV. Getting it? It is the same concept. There you had two positives. Here you have two negatives. There it is called as something called as the M pattern, and here it is called as the W pattern. Amritsar has asked, shouldn't it be a negative R wave? So the thing you are misinterpreting. Yes, the deep wave is because of muscle conduction in the right ventricle. But Amritsar, what you fail to see is this figure. Can you see how much thicker the left ventricle is compared to the right ventricle? So this is like saying that Vijay Mallya is bankrupt, but still he's living a much more comfortable life than most of the Indians, right? So that is the concept here. The left ventricle is so big that anything will have a much bigger impact in the left ventricle. Like the left ventricle will always have more impact on the EKG. And as your question is from Andhra Pradesh, in normal EKG, you are not ignoring right ventricular contraction. You cannot detect a right ventricular contraction because it happens, it starts and ends till the time the left ventricle starts and ends contracting. So it is not severe enough to get detected. Yes, current is from the right now. That's why you have a deep deflection here, right? So see, you had an S wave here also. I told you the left ventricle is always going to have its impact on an EKG. It is always going to demand more magnitude of current. Is it clear, Amritsar? Okay. So this is how it appears. This, when you see the R, S, R dash pattern, is characteristic of a right bundle branch block. If I have to diagnose right bundle branch block in 5 seconds, I would only look at the right sided electrode. I would not bet my money based on the left sided electrodes, left sided leads, because right sided leads would give me a much better picture of the right sided pathology. So right bundle branch block I would understand much better on the basis of right sided leads. So this is how you would diagnose a right bundle branch block. You can see that there is an R dash pattern in V1 and it is continuing in V2. The V6 is, you can say, it's more like an equiphasic electrode. So it's more important that you look at V1. You can note it, if the QRS complex is normal in duration, it is called as a partial right bundle branch block, and it is called a complete right bundle branch block only if it is prolonged. Now I like to give you all a 10-minute break before we move on to left bundle branch block. I want you to reflect upon it a bit so that I just don't keep teaching you in a haste. And also I think you need some recovery from all the medicine that we have been through. We'll get back to you in 10 minutes. Okay? Or you don't want a break and you want to continue? Okay. Break. I hope you are ready. We can start. Okay. So when we consider this the whole scenario for the left ventricle and the right ventricle and everything. So the only main confusion that you get is what stays positive and what stays negative, right? That is the only thing that bothers you. How is it negative? How is it positive? What you need to remember is the left ventricle is always going to have an impact. It's never going to be such that left ventricle just disappears from the EKG. It is always going to be there, very much there, and it is always going to be more powerful, it will have a higher magnitude than the left ventricle. The S is not normal. The S might not be so well present in case of why S is present in a normal V6. In normal V6, it is not very well refresh. So in a normal pathology, it is said that in normal physiology, in EKGs, it is said that the S wave is because of delayed depolarization of the posterobasal septum. It has nothing to do with the right ventricle. Now exactly it is not known, but it is just the direction of the ventricular depolarization that results in the S waves. That is what you need to remember. Why is the S equivalent in normal V1? S is not equivalent in normal V1. What do you mean by equivalent? S is way smaller in normal V1. Way bigger. S in the normal V1 is because of the left ventricle. In a normal V1, it is something like this, right? So this is your R and this is your S. Second peak, that was the whole concept why we were talking about the right bundle branch block, right? That it was because of the right ventricular contraction that happened there. See, some things you have to understand. One is when you're talking about V1, you're looking from the right ventricular point of view, and when you're looking at V6, you're looking more from the left ventricle. Problems of the right side would be more manifest on the V1 than on the V6. That you need to understand. Is it clear why we have the second peak? This peak is because of the right ventricle, that is in the RBBB pattern. So now we'll be talking about the left bundle branch block. When you consider the left bundle branch block, what has happened here is from your SA node to your AV node and down your two fibers. If you considered this to be your left bundle and this was your right bundle, now the left bundle is no longer functional. When the left bundle is no longer functional, the right bundle will have to do all the work. What happens is, when you were considering the right ventricular wall and so this was your right ventricle, the septum, and this was your left ventricle. I just made it so because my photo would interrupt this image. So this is your thickness of your left ventricle. I'll just redraw it here. What we are talking about is your RV is way more thinner than your LV. So left bundle branch block would be a more severe problem because right ventricle already is a thin muscle. Right ventricle was already having a disadvantage on the EKG, and all those disadvantages will only become more manifest. I'll repeat, already the left to right, right to left, the ventricles were going. The ventricular depolarization was already right to left. Now it would be more left. The septum, however, this part here was left to right. But now there is no left bundle. Because there is no left bundle, this will also become right to left. Is it clear? So, septum earlier was left to right, now it becomes right to left, and the ventricle already was right to left, now becomes right to very left. So the activation which used to take place in the left ventricle will now take a much longer period of time. So I'll just write it here. The septum in left bundle branch block would be right to left. That is the septum. The ventricle would also be right to left, but this was already right to left, but just it is more prolonged because now the conduction is happening through the ventricles. So when I look at V1 now, what was the first deflection in V1? It was the septal deflection. What was it? It was positive. Why is it positive? Because it was from left to right. This left to right deflection is now right. The earlier left to right deflection of the septum is now right to left. That means it is going away from V1 and will result in a negative deflection. What used to come in V1 after a negative deflection? V1 used to have a positive deflection, that was called the R, and then a deep S wave because of the right to left contraction. Suddenly it has more negativity. So this would be a merged down wave like this. It will have, mostly it will have no R wave, or it will have a very small blib of an R wave. A very small blib and a very deep S wave. This is a pattern of V1. So sometimes it may present with something like this, a notch. But for all practical understandings, you have to remember this pattern. Small blip followed by very deep S wave. When you talk about V6, as we discussed, a left-sided pathology would be best visualized on the left side. We just spoke about it. So for the left side, the septum goes left to right, resulting in a positive deflection. The ventricles go right to left. Now that would result in a positive deflection. That means everything is now moving towards the left side. So everything here should be a positive deflection. And this is how it looks like. This is because of the septum. This small is here because of somewhere because of maybe the RV, and then here is because of the left ventricular contraction, left ventricular depolarization. So this M pattern in V6 is characteristic of left bundle branch block. Is it clear? There's a pin drop, a silence on your screens, so I want you to answer. Yes, once again. Yes, yes, yes. Okay. So the thing here that we're talking about is, it is very simple to understand a left bundle branch pattern. the thing in left bundle branch pattern is every left ventricular manifestation on the EKG will be worsened. Left ventricular manifestations of the EKG would be worsened or increased. So V1 was predominantly negative lead RS pattern, that S becomes super S wave, very big. V6 was supposed to have a QRS complex. Q wave was because of the septum. There is no septal depolarization because of LBBB. Septum is going from the right to the left. So even that becomes positive. V6 lead was already positive. So that stays positive. And finally, you get something like an M pattern. Is it clear? What you have is something like this. So it's called the W and the M. I don't want you to remember it this way. I want you to remember the basics of it so that you can teach your great grandsons also. Is it clear now? Pune, Goa. V1. Why V1? So V1 here, there is no, so the positive and negative that was happening in V1, that is, sorry, positive followed by negative that was happening in V1. This positive was because of what? This was because of the septum. And how was the septum getting depolarized? Normal conditions. It was from left to right. But if the left bundle is blocked, this is the left bundle branch block, right? So now the septum is getting depolarized from right to left. As everything is moving in the left direction, V1 would have what? V1 would have the Great Depression, and that's what you're seeing there. For the M pattern in V6, it just denotes that everything is super positive. The initial positive that is before this positive here is because of the septum. Septum is moving from right to left. And this here is, this here is because of the ventricle, which is getting depolarized from right to the left. Everything is moving from the right side through the muscles into the ventricle, and that's why it is super positive in V6, super negative in V1. Is it clear? Goa. Nehru Nagar. Great. So why we need to understand this? Right bundle branch block can be physiologic. Tall people may have, or young people may have, a right bundle branch pattern. It can be physiologically seen. It is not sacrosanct. It does not mean that anytime a right bundle branch is present, it does not mean that there is a problem. It can be present normally. When you're talking about the left bundle branch block, it is always present in pathology, and the most common pathology a left bundle branch block is present is myocardial infarction. So MI is the most common and the most important pathology left bundle branch block is present in. A patient presenting to you with sudden onset left bundle branch block can be having myocardial ischemia. The subendocardial layer, where the conducting fibers are present, is the most vulnerable for ischemia. This is the reason why ischemia results in left bundle branch block. Clear? Are you clear with the etiologies? So what we have tried to cover is axis, understand how the EKG was developed, how we moved ahead, how we trapped it into quadrants. We understood the left quadrant is axis is the lead one and the down quadrant is AVF. So anything in both these quadrants would be your normal axis. Anything which is not on the left side would be on the right side. Anything on the right side and down would be right axis deviation. Anything on the left side but up would be a left axis deviation. Anything not on the right side but not down would be an extreme axis deviation. Then we saw the rate. For the rate, we understood that the stylus does not move, the paper moves, and the rate is determined on the paper. And this paper is nothing but your which has large boxes and small boxes. The rate is 25 millimeters per second, and you have to divide the number of large boxes by 300. So 300 divided by the number of large boxes will give you the heart rate. 3 to 5 is the golden number. If there are 3 large boxes, if between 2 RR intervals, you're good. If there are 5 large boxes, you're good. Anything more than that or less than 3 is tachy or bradycardia. Then we came to the sinus rhythm, where we saw the prolonged PR intervals. We saw the sinus and how it can be a complete heart block. Then I blew you away with your bundle branch blocks. This is the amount of things we have covered. We have gone from tip to almost covering, if you think of it, at least 40% of EKG is covered. If you are through with this, you can answer 40% of your EKG questions. All you would require is practice. Everything apart from that, we will approach now. So we'll come to a case scenario, and I would be asking the question in the form of what is the appropriate therapy. The only reason to do it is so that we can go to the end and not just be very superficial in our approach, because medicine is about treatment, right? This is a generic question and a conceptual pharmacological question which asks, a 58-year-old female presents to the clinic for follow-up. She is being treated for congestive heart failure secondary to dilated cardiomyopathy. Patient has an implantable cardioverter and defibrillator. She was found to have sudden runs of ventricular tachycardia and has persistent atrial fibrillation. Her past history is non-significant. Her temperature is 98 degrees Fahrenheit, pulse is 90 but irregular. Her respiratory rate is 28 per minute. The patient is planned to be started on amiodarone. Which of the following tests must be performed before initiation of therapy? Before I move ahead, I'll just take 5 minutes of your time to help you understand how we approach a big question. It's not a matter of which exam you're going to give it in for. What is important is you learn the right approach. Whenever the question stem is more than 2 lines, it means it's a big question. It's a long question. When you're answering long questions like this, as you saw, we read a lot of irrelevant material and we invested time understanding the question, but what we were talking about was only amiodarone and what test needs to be performed before initiation. This was the only question that we were trying to answer. So when you have this small a question, it becomes very important that the first thing that you do when you read an MCQ is read the first line. This is the first thing that you do. You read the last line, sorry. You read the last line, and that is the most important thing to pursue. If you see something like this, you go ahead with the next line before that. And this way you form an approach. Always try and think why this question is being asked. Amiodarone is one of the most commonly used antiarrhythmic drugs. As it is a commonly used antiarrhythmic drug and it is associated with wide range of complications. So as it has a wide range of complications, it needs to be sorted out. You need to be very sure that you are not going to worsen your patient because of this drug. So as I saw some of you are very enthusiastic in answering, I would give you the options now. Liver function test, pulmonary function test, sleep study, echocardiography, and fundus examination. Echocardiography. I've got the first answer. Thyroid is not an option, Kolkata, so I think you need to think again. Nehru Nagar says B. Kolkata says pulmonary function tests. Echo. Okay. So when you see this question, the question that is being asked is, which of the following would be worsened the most by amiodarone? The question is, which of the following complications is the patient most at risk for? If you have to start amiodarone in 100 patients, okay, and you need to evaluate 100 baseline things, 100 complications amiodarone can do, you want to evaluate for 50% complication rate. Anything that it has a high complication rate, you want to evaluate for. Fundus examination, eye complications of amiodarone are very common, like corneal deposits. But it is not very severe. Also, when you're comparing arrhythmias with corneal deposits, you don't mind the corneal deposits. So fundus examination can be ruled out. If a patient is already having atrial fibrillation, ventricular fibrillation, ventricular tachycardia, ejection fraction of 20% with dilated cardiomyopathy, with chronic heart failure, what is echocardiography going to help you with? You already know that the cardiac status is very bad. Amiodarone does not have a significant inotropic or a chronotropic effect. So it is safe that you can give it in chronic heart failure also. So echocardiography gets ruled out. What? Sleep study, that would be obstructive sleep apnea, has been recently found to be associated with lot of complications, especially with chronic congestive heart failure. Chronic congestive heart failure will lead to something called as a Kine-Stokes breathing. So that would be a type of sleep apnea which is central sleep apnea, and it would be present with chronic heart failure. Having central sleep apnea does not contraindicate amiodarone use. So sleep study is not indicated in this patient. Now you are left with only two options. Chronic heart failure is associated with central sleep apnea, called as the Kine-Stokes breathing. Physiology 101. Oh, I'm sorry about that. So it is associated with central sleep apnea and Kine-Stokes breathing. So that's why you do a sleep study. That is the only indication for sleep study in a patient of chronic heart failure. But having central sleep apnea does not contraindicate the use of amiodarone. So that is why you can use amiodarone in patients with chronic with central sleep apnea. So that's why you ruled out sleep study. Now you have two options left: pulmonary function testing and liver function test. Of these two, amiodarone is known to cause complications in both the varieties. It can lead to transaminitis, but hepatitis or fulminant liver failure is not a known complication of amiodarone. Also, transaminitis because of amiodarone is not a contraindication to starting amiodarone therapy. So that is why the most important step before starting therapy is pulmonary function test. Also, thyroid would have been a right answer, but now it has become so common that I don't believe anybody would ask you this question. Everybody knows thyroid, and it causes hypo as well as hyperthyroidism. So pulmonary function testing is important because amiodarone results in chronic interstitial pulmonitis resulting in pulmonary fibrosis. Pulmonary fibrosis, and you want to monitor these patients that they are not developing pulmonary fibrosis, which is the reason you start them. You first do a pulmonary function test. A little bit about amiodarone. It is a class 3 antiarrhythmic drug, which is very broad spectrum, very potent. It is used in all ventricular tachycardias. All ventricular tachycardias can be treated with amiodarone, especially structural heart diseases. Make a note of this point. Mechanism of action, it has various mechanisms of action. That's why it's a broad spectrum drug. It is inhibitor of potassium channels. It inhibits adrenergic stimulation, affects sodium and calcium channels, and decreases AV conduction and sinus node function. Notable side effects of amiodarone. It is very important to understand the side effects of amiodarone because amiodarone is associated with a high complication rate and it has a high usage rate. That means you use it so frequently that understanding its complications becomes vital and crucial. It leads to QT prolongation, and QT prolongation leads to something called as torsades, which is a type of ventricular fibrillation. Chronic interstitial pulmonitis, hypo and hyperthyroidism, transaminitis, hepatitis, but it is not fulminant hepatic failure. Corneal microdeposits, optic neuropathy, it is a rare complication. A characteristic complication would be skin pigmentation, also called as a blue-gray skin, and it can result in neuropathy. So these are the complications of amiodarone use that you need to remember. So before initiation of therapy, chest X-ray, pulmonary function testing, and thyroid function tests are done. If a question has to be formed on the use of amiodarone, it would be either the patient is having long-standing arrhythmias for which therapy needs to be initiated, or patient was taking a long-standing drug for a long time and now has developed some complication because of it. These are the ways a clinical question might try to hint that they want you to answer amiodarone. Any doubts regarding this? It is a very straightforward. I think it would be covered in your pharmacology also. It's very simple, run-of-the-mill kind of a question. Should we move ahead? Okay. So we will come to the main maid of honor today, and that is EKG questions. A 68-year-old male presents with a history of diabetes and hypertension to the clinic with complaints of palpitations and dyspnea for the last 1 month. The palpitations were present even at rest and seemed irregular. His medications include enalapril, hydrochlorothiazide and metformin. His temperature is 98, pulse is 90, irregular, his BMI is 23, EKG is shown, and here it is. Before we try to answer the EKG, let's complete the question. What is the most appropriate next step in management of this patient? As step 1 aspirants, I would say, okay, you can skip about the management part, but what is more important is what is the diagnosis. To approach the diagnosis, first ask yourself the questions you have been taught. What is the axis? What is the rhythm? And what is the rate? Try and answer this. What is the axis in this patient of this EKG? Normal axis. What is the rate? Tachy. Is it regular? And is it sinus? What is the rhythm? Irregular, correct. What is the rhythm? Junctional. Okay. Why do you say it's junctional? Why do you say it's... Do you realize where the P waves are? Can you see the P waves? Narrow QRS. It's a good answer. But do you see where the... Do you have a P wave or you don't have a P wave? You say there is no P wave. Can you see now? Which are these waves which are present here? This waves. This waves. Do you see those wavy things? There are lots and lots of P waves. Can you see a lot of P waves? See, all of you are jumping to the diagnosis, and that's the only thing that is preventing you from answering this question. You're trying to answer the question, you're not trying to solve the condition. There are a lot of P waves and there are irregular QRS complexes. Tell me, in complete heart block, can you have tachycardia? When the ventricle is dictating its own rhythm, how can you have tachycardia in complete heart block? You cannot. What is the idioventricular rate? It is 35 to 50. If the junction could result into tachycardia, then the sinus node will not overrun it with its rate, right? The sinus node dominates the rhythm because of its rate. Complete heart block cannot result in tachycardia. A condition where the atria is contracting too many times is called as, it's a type of atrial tachycardia, and it is atrial fibrillation. Somebody answered it correctly. It is atrial fibrillation. What you mean by atrial fibrillation is, if this was your atria and this was your ventricle, okay? Atria contracts and the ventricle contracts. Then the atria contracts, then the ventricle contracts. Suddenly, the atria starts contracting a lot. All the impulses cannot be transmitted to the ventricle because of a node called here the AV node. The AV node will regulate some of the contractions. But what if different segments of the atria start contracting like this? When the atria, rather than contracting as a single unit, starts contracting as fibers, it is called as atrial fibrillation. Atrial fibrillation can be seen by all these numerous P waves that you can see. As there are so many different P waves, that means the whole of the atria is not contracting as one, it is contracting as many. If this is your SA node and this is your AV node, what was supposed to be was there would be one conduction that comes to the AV node and this goes down the bundles. This is how it was normally supposed to be. But what happens now is the different parts of the atria are getting activated. When the different parts of the atria get activated, this jumps in, here it jumps in, here it jumps in. So this contraction turns into a flutter. Alright, there is activation of different parts of the atrial musculature. The AV node will not transmit so many impulses to the ventricle. What this will do is, this will transmit only some. That means the AV node will get activated, then it will go into refractory period, then again it will get activated, then it will go into the refractory period. This is the reason at irregular intervals it will transmit some of the electricity from the atria to the ventricle, which will present as irregular QRS complexes. Irregular QRS complexes. Multiple P waves are seen with irregular QRS complexes. Always think of atrial fibrillation. Atrial flutter is a condition where the atria is contracting as one unit, but at a very high rate. Because of this high rate, there is something called as a 2:1 or 3:1 block. That means after every third impulse that hits the AV node, will one node pass into the ventricle. So there it would look something like this. So this pattern, called as a sawtooth pattern, because of so many P waves, a sawtooth pattern is seen in atrial flutter. In flutter, the QRS is normal, the duration, because the atria is contracting as one. When the atria starts contracting as a different unit, then there would be different rates and different contraction of the QRS complexes. Atrial flutter is the most common cardiac arrhythmia globally, worldwide. The cardiac arrhythmia present with the highest morbidity is atrial fibrillation. Very important topic throughout your lives. Is it clear how we diagnosed it? There are irregular PR intervals. PR interval is irregular. PR intervals are irregular, and there are multiple P waves which are getting activated. You can see any lead for an arrhythmia. For an arrhythmia, you see the rhythm strip. What you mean by the rhythm strip is lead 2. You can check the rhythm strip, and when I said by the most common part is atrial fibrillation is the most common type of arrhythmia present today globally. So it's a very important arrhythmia. Now there are certain pharmacological principles when you treat an arrhythmia. The pharmacological principles of arrhythmia treatment are, I'll tell you this way, that this is the conduction system of the heart. So this is the atria, this is the ventricle, and something like this. Looks funny, but it is what it is. So the atria is contracting, and then is the ventricle contracting. So it is atria and ventricle. If you want to treat an arrhythmia, what is the dreaded complication? The dreaded complication is the ventricle will start contracting so much that it has no time to fill up and it will not eject out properly. So when it has no time to fill up and it does not eject out properly, the patient will have hypotension, the patient will have stroke. That is the dreaded complication of any arrhythmia in the world to a person. You do not want him to have a circulatory compromise. That is what you are most concerned about. Okay, please try to focus on what I'm saying rather than just trying to answer the questions, because you can read the answer anywhere you want, right? So this is what I'm trying to tell you. So what we are trying to achieve through every arrhythmia is control the ventricle first, because if the ventricles is not controlled, you will not have a proper management of arrhythmia. So when you're talking about the answers that you have given me, it is for the AV node blockade. You say block the AV node. But the methods you suggest, which is a carotid sinus massage or a vagal massage, are very temporary measures to stop AV node. That is, it will temporarily increase the vagal tone, and then it will result in stoppage of the impulses being conducted down to the ventricles. In cases of atrial fibrillation, it is ineffective. You do not use vagal massage or carotid sinus massage in cases of atrial fibrillation. Hence I said, please pay attention to what I am trying to tell you. The management of atrial fibrillation can be understood that it has one, either control the atria, to control the ventricles. Please make a note of it. Management of atrial fibrillation is either control the atria or control the ventricles. Controlling the ventricle is always an acute emergency. Controlling the ventricles is always the first priority. When you say control the ventricle, it is called as rate control. Clear? When you say control the ventricle, it is called as rate control. When you say control the atria, it is called as rhythm control. So when you read about atrial fibrillation, when you solve about atrial fibrillation, anywhere you go, if you have this concept in your mind, you want to control the atria, you call it rhythm strategy. That is, until and unless you convert the atrial fibrillation rhythm to the normal sinus rhythm, the atria will keep on contracting like this. But if you control via a beta blocker or diltiazem, what you're trying to control is your ventricular rate. That is an immediate strategy, not the long-term dependent strategy. Am I clear with this? Is this point of atrial fibrillation management clear? Adenosine would not be an appropriate management. Why? Any ideas why adenosine is not appropriate management? Kolkata. If you only want answers, Kolkata, there is no point of a class, unfortunately. Why is adenosine not the right answer when carotid sinus massage is? What we were saying is ventricular contraction, when you control it, when you control the ventricular contraction, it is called as a rate control strategy. And when you control the atria, it is a rhythm control. You have to change the rhythm from an atrial fibrillation to a sinus rhythm. The last part was, it is for supraventricular. Yes. In atrial fibrillation, we first control the ventricles, and that is through rate control. So we give drugs which have negative chronotropic action, which is diltiazem. So you are using drugs which have a negative chronotropic action, which is diltiazem, so that the ventricles have time to fill up and the hemodynamic status is not compromised. Is it clear? Do you have your answer, Kolkata? Lidocaine is used for ventricular arrhythmias. It is not used for arrhythmias originating in the atria. Adenosine is very short-lived. It is so short-lived that you have to give the injection in the brachial arteries. If you give the injection in the brachial arteries, only then does it reach the heart. If you give an injection in the peripheries, it won't even reach the heart. It is that short-lived, and that is the reason why adenosine cannot be used. Is it clear? Lidocaine is more used for ventricular rhythms. It is not ventricular arrhythmias. It is not used for arrhythmias originating in the atria. Lidocaine can control, but it is not acting at the pathophysiologic level to control what we really want. What we want right now is negative chronotropic action, which is best by diltiazem, better off by beta blockers. So we'll be talking about atrial fibrillation. So atrial fibrillation is the most common type of arrhythmia. We just said the things that you need to know is these features would be present almost in all arrhythmias. So clinically, it is very difficult to try and tell what kind of arrhythmia we are dealing with. The examination finding, which is characteristic for atrial fibrillation, is irregular pulse. The pulse would be irregular in most of the cases. In all of the cases, not most of the cases. So this is how you're going to diagnose them. First thing that you saw was the axis. You saw the axis AVF and 1 were both in the normal range, so it was a normal axis. Second thing you saw was the rhythm. You could see that there were a lot of P waves and the rhythm was seemingly irregular. You cannot say if it is sinus or not, because in complete heart block there would be two things that you require. Complete heart block, first the RR interval is constant. That means the contraction is constant. Most common is fibrillation, not flutter. The RR interval in complete heart block is constant. And secondly, you expect bradycardia. So with the basis of these two, in an exam you can go fast forward and say that this is not complete heart block, which a lot of you were confused about. Fibrillation, again irregular. Flutter, again it should not be irregular, and there should be a constant block like a 2:1 or a 3:1 block. So it would be a very high atrial rate like 200s or 300s with associated heart block. So the ventricular rate would be, if it's a 3:1 block, so it would be 100. So the atrial rate of 300 and a ventricular rate of 100. So the first question that you have to ask, I just said the differences between flutter and fibrillation on an EKG, Pune. I just made you this diagram, right? This is flutter. Flutter will have yes. How would you determine regularity by if you palpating a pulse? What are you palpating? You're palpating the QRS intervals, right? The ventricular contraction is what gives rise to the pulse. If a pulse is irregular, that means the QRS has to be irregular. To differentiate between a flutter and a fibrillation, fibrillation has to be irregular. Flutter may or may not, is usually not irregular. It should not be irregular. Is it clear? So the rate control drug of choice would be beta blockers, calcium channel blockers, and rhythm control is amiodarone and dofetilide. At your level, you should not be much concerned about which drug is used, how it is selected. It is more about the pathophysiology which you are targeting rather than the individual, rather than you have to remember what the specific drugs are, because as you move ahead you will understand why, what is being used, how it was selected. What you need to understand is what is basically going wrong. Do you want to move on to the next question, or do you have more questions for me? Kolkata, were your questions answered? I don't see Kolkata. Kolkata, yes. Next question. Kolkata. Okay. All right. The last option is, let's just forget it. Which is the next most appropriate management? Diabetes, hypertension presents to you with palpitations. Palpitation was present at rest and seemed irregular. Drugs include enalapril, hydrochlorothiazide and metformin. Patient has suffered from anterior cerebral circulation infarction 1 year back. His temperature is normal. What is the most appropriate management. This is your EKG. I'll just zoom the rhythm strip so that you can notice it. I'll help you out in this. If you have to map out the RR intervals or any of the, what you do first is you affirm that this is axis, this seems to be, this may be taken as an equivalent one. Even then AVF is positive, so it's either a normal axis or a right axis deviation. The rate is definitely, this is tachycardia. You see that there is less than two large boxes here. So this is definitely tachycardia. Now, when you say tachycardia, it does not stop at that. What you need to assess is what was the next beat after tachycardia. And this was a longer beat. And after that, again, you have a short beat and then you have a long beat. This is somewhere in between, longer, short, long. That means it has no rhythm. Again, tachycardia, no rhythm, atrial fibrillation, until unless proven otherwise. You can see a lot of blebs here, which can be P waves. It seems like P waves. If you see here, if you see at least 3, you can definitely just map out the P waves. There are two or three P waves here, at where my hand shows you, here, then there is one here. So this is atrial fibrillation. P waves, tachycardia, irregularity. 3 things we used to determine that. Okay, the question is, what is the best next step in management? D. Amiodarone, metoprolol, enoxaparin. Others: Kakinada, Kolkata, Nagpur, Goa. D. A. D. Okay, so one more pathophysiologic concept. So the answer is metoprolol and enoxaparin. Enoxaparin is heparin, low molecular weight heparin. So there's a concept which you need to understand here. When you're talking about ventricular fibrillation, what happens is, you have the atria which is not contracting fully. Okay, the atria is not contracting fully, which leads to stasis. Atria is not contracting fully, it is contracting like this, resulting in stasis. Do you remember the Furcow's triad? The Furcow's triad. I hope you know that this is F, not V, and it is not Virchow. It is pronounced F. You're going to the US, you can't call it Fur. You have to call it Fur, not Ver. So Furcow's triad, you have stasis, so this results in thrombosis. Exactly. So this will result in thrombus formation. It will build up a thrombus here. What lies below the atria? Definitely the ventricles. So you have the LV and the RV. Alright. Yes, stroke. So what happens here is, because the atria is not contracting fully, till the time it is not contracting fully, the thrombus stays in the atria itself. The moment you control the atria, remember we said this, ventricular control first, then you control the atria. That is rate control followed by rhythm control. The moment you control the atria start contracting normally, they will spit out this thrombus into the LV. And LV will throw this thrombus into your brain. And that patient develops a stroke. So the patient presenting to you with shortness of breath now suffers from stroke, which is even worse. Did you get this point? The atria was not contracting well. This led to a formation of a thrombus. Now suddenly you made it contract very well and the thrombus got dislodged. And that led to boom, a stroke. What do you do if there is a thrombus? If the patient has had atrial fibrillation for more than 24 hours, any patient who has had atrial fibrillation for more than 24 hours, you want to know how high is his chance to develop thrombus. If a patient has atrial fibrillation, you want to know, will he develop a thrombus or not? Okay. By knowing this answer, his chance of developing a thrombus, you decide should you thin his blood or not. To decide should I thin his blood or not, you need to know what is his chance to develop a thrombus. This is calculated on the basis of a score called as the CHADS2-VASc score. This score helps to identify people who are at a higher risk of developing a thrombus. You will have to unfortunately memorize this score. It is a very simple score because the mnemonic is its name. CHADS, C stands for congestive heart failure, H stands for hypertension, age, diabetes, stroke. So if he has a stroke in the past, obviously he's at a high risk for developing stroke again. Vascular disease, age and sex. Females are at higher risk for developing coagulative problems. Anywhere you read it in medicine, you should always remember that. If a patient has a score more than 2, you will have to anticoagulate this patient. So here in our patient, the patient had hypertension, you give him 1 score. The patient has an age more than 65, you give him 1 more score. And the patient is a male, so he gets 0 score for that. He has diabetes, so he gets 1 more score. So he has 3 scores already, a score of 3. And he has a history of stroke. So his CHADS2-VASc score is 4. So he definitely requires anticoagulation. Any patient who requires anticoagulation, you cannot give him atrial control therapy initially. Amiodarone will be a atrial control therapy. We wrote it. Amiodarone and dofetilide are used to induce sinus rhythm. Are used to induce sinus rhythm. So you do not want this to change into this before the patient is properly anticoagulated. That is the reason this question is very frequently asked in all of your exams, including your boards and your university exams, the importance of anticoagulation in case of atrial fibrillation. As I already said, atrial fibrillation is one of the commonest causes of arrhythmias. So this is how you manage atrial fibrillation. So first thing you see is the patient hemodynamically stable or not? Second thing that you see is, does this patient warrant anticoagulation? You control the ventricles first, you thin the blood if required, and finally you control the atria. This is how you proceed for atrial contraction. The anticoagulants that you use, you start with a heparin bridge with warfarin. Any ideas why? Why you start with, you give the heparin bridge with warfarin? And the newer anticoagulants which have been approved are dabigatran, rivaroxaban and apixaban. Warfarin takes 7 days to do what? Any others? Why do you give heparin bridge therapy for patients with warfarin who have been started on warfarin therapy? Any better answers? Do you know how warfarin acts? Thrombus forms. Do you know how warfarin acts? Yes. So it acts via stopping the vitamin K carboxylation, right? So it acts on both. It acts on clotting factors as well as anti-clotting factors. Warfarin acts on both. It acts on clotting factors and it acts on protein C and protein S. The earlier effects of warfarin are on protein C and protein S. What do you mean by why? Why does it act on protein C and protein S? I didn't get that question. It acts on protein C and protein S. But the half-life... Oh, sorry. So I'm really sorry about that. It's a funny moment. So it acts on protein C as well as protein S. And the half-life of protein C and protein S is less than 2, 7, 9, 10. So protein C and protein S will go down rapidly. So initial days of warfarin, it is a procoagulant and not an anticoagulant. Initial 3 to 4 days of warfarin use, it will act as a procoagulant. And that is why you need a heparin bridge, because you want to tide over that period. So the most famous complication that is asked in entrance exams about warfarin use is skin necrosis. The most important question that is asked is skin necrosis. Warfarin induced skin necrosis. When you go back today, just look it up. And that is the reason why you have to start always with warfarin bridge mechanism. Okay. So before we wrap up for the day, this is a interesting, funny, easy to treat condition. It's not easy to treat. I mean, easy to treat in your MCQ exams. Any idea what is going on? What is the axis like? VF, correct? Axis. Where is the axis? So whenever you call fibrillation, so you cannot call it a normal or an abnormal axis because you don't know the baseline. You do not know the baseline in these conditions, and hence you cannot call it where the axis is present. Is it increasing, down, up? You just can't know. When you say something as fibrillation, what it means is the individual fibers are contracting. The individual contraction, which should be this, is now suddenly changed into this. So when the ventricles start to fibrillate, it is a near death call. It is a near death call, because if the ventricles are not contracting, there is no way a patient can be hemodynamically stable. This condition, as rightly said, is a ventricular fibrillation. It is a ventricular haphazard contraction. Any of this condition, you have to go ahead with the most immediate kind of therapy. See, heart is a muscle. It is pumping blood. If it is pumping blood, blood is reaching all the organs. If the heart is not functioning, how can you give an oral antibiotic or any intravenous drug? You cannot. So you cannot give an intravenous drug. You have to give something called as a electric shock. This electric shock, as I see, there is a bit of confusion in what it is called. When I see that this rate is such, when I see that there is a tachycardia and I want to shock this patient with this rhythm, what I do is I put my sensors of the plate would be such that they would give the shock, they would deliver the shock on the R, that is on the height of your QRS complex. That is when it shocks it. And this, when it is synchronized with your R, wave, it is called as synchronized cardioversion. This is to instill sinus rhythm again. What you're trying to do is you're trying to shock your heart so that your SA node can take charge. Again, SA node will take charge only by rate. You shock your heart so that your SA node comes up and starts covering for it. Is it clear? This condition, this process is called as synchronized cardioversion. In cases of ventricular fibrillation, the rhythm is something like this. Do you see, is there any QRS complex which is present here? As there is no QRS complex, there is no way your paddles can identify the R waves. There is no synchrony between the electric shock and the heart depolarization. Such a process is called as defibrillation. When you are just administering the shock, you're just giving the shock at any phase of the cardiac cycle, it is called as defibrillation. When you are doing it at the height of depolarization, you call it synchronized cardioversion. Other differences is because this is synchronized, this would be say 100 joules. But in defibrillation, because it is asynchronized, it is not in sync with your cardiac contraction, it has to be very powerful, say about 300 joules. It is the same machine, it is the same paddles, it is the same way the person would say, I am clear, you're clear, everyone clear, stand out, clear away. It is the same process. But it is, the difference is on the basis of cardiac cycle. I hope this point is clear. So what would be the answer in this question? It would be defibrillation. So you've been asked for the EKG. What I'll do is I'll stop on that. So ventricular fibrillation is a very common arrhythmia around MI. When a patient develops acute heart attack, acute myocardial ischemia, VF is the most common cause of sudden cardiac death. So it is never because of a very massive heart attack that a patient suddenly expires. If he expires, it is usually because of a sudden onset ventricular fibrillation. It is the easiest EKG to decipher just because there is so much chaos in it. There is so much chaos in it that the patient can never have a normal rhythm. Okay? So it is simple, treat it, shock it. In any arrhythmia, if there is hemodynamic compromise, your drugs are useless. They cannot reach the heart if the heart does not pump the blood away. If the heart does not pump, the blood cannot reach it. So any intravenous drugs you cannot use for that time. You have to shock. You have to either do a cardioversion or you can have a defibrillation. Do you have any doubts so far? I would because we have 2 more days to go, I would like to know in general you lost network where, Amritsar? Amritsar, you lost network where? So Amritsar, we did not cover much. We just said about this. We said if there is chaos on the EKG, you need to give a defibrillation because the heart is not contracting. So in such a condition, there is no utility of any of the IV intravenous drugs. So the topics for tomorrow, we would be talking more about EKGs. I would be talking about tachy and bradycardias. We'll be covering about heart sounds, like how the murmurs are generated, how can you approach a question of murmurs. I believe EKG would take us say an hour and a half more.